Hello and welcome to our talk about Senior Resident Simtending Curriculum, a novel simulation-based transition to practice. I'm Kimbia Arno, and at the time of this recording, I'm the Simulation Fellow at NYU Langone, and I graduated from the Rush University Medical Center Emergency Medicine Residency Program.
And I'm Sara Hock. I am the Emergency Medicine Simulation Director at Rush.
So just to start off with a little bit of background, there's a very limited set of curriculums that focuses on the transition from senior resident to attending. There's a lot of data that's just that new attendings feel that they're well trained in their medical knowledge, but frequently have the sensation of having a gap in their non-clinical responsibilities, which includes things like supervising residents and also balancing that resident supervision with clinical care and giving their residents enough latitude to learn on their own. And there are relatively few or really very few dedicated pedagogical structures due to the fact that residency really tends to focus on the clinical skills, but then doesn't really focus on that much beyond that. So the purpose of our curriculum was threefold. We wanted to give senior residents the practice of supervising learners and also formal space to practice teaching. We wanted to simulate the balance of relinquishing control while maintaining patient safety. And we also wanted to provide a new focus for senior residents who frequently get a little bit disengaged towards the end of their training when it comes to simulation cases, especially because we typically focus on the clinical knowledge portions. So Rush is a 3-year residency program in Chicago, Illinois, and that's where we kind of initiated this program. So the Simtending model, just to explain it a little bit, is really a set of three, typically, three groups with 3 PGY3s and typically 1 to 3 junior residents. Frequently, interns are paired with PGY3s, but sometimes second years will be paired with PGY3s as well. So in a typical group, you would have 1 PGY3 who's in the attending role with the junior resident staffing with that attending as though they were attending in the emergency department. There's a second PGY3 who is in a teaching role, who has the case in advance that has specific clinical teaching pearls that they're responsible for preparing for prior to the case that they will participate in the debrief afterwards. And then lastly, when you have the third PGY3, they usually are in the observing role. So they'll just kind of be there to watch the case and kind of give their sense of feedback of what's going on. And then the PGY3s will all get feedback, not just from the faculty, but also from their juniors regarding how they were as an attending and how they were in terms of like giving their residents space and, delegating tasks. The reason you have 3 groups is it allows those, the 3 PGY3s to rotate through each of those roles once. So they all, in a given simulation session, will have the opportunity to be the attending, the opportunity to be a teacher, or the opportunity to be an observer. And throughout the year, we extracted data from anonymous satisfaction surveys for each of the simulation sessions that we did. So specific to our program, we do a lot of simulation. We do about 20 cases a year, I think, or 20 sessions a year, I think. 50% of them are in the in situ session, or sorry, in the in situ setting, in the emergency department. That's interprofessional, more focused cases. So we're working with nurses, we're working with techs, we're working with pharmacists. And then the more physician-directed simulation sessions tend to be in the simulation lab. And that's really where we focused our Simtending curriculum or model, so we could have really the residents kind of focusing on that specific set of tasks. And those cases tended to be high acuity but low occurrence cases, so they could really focus not just on their clinical skills for the junior residents, but also how to deal with high acuity cases while managing the junior residents during the case. So after we kind of got some data, we decided to take a look at it. So we did 74 surveys across 6 discrete simulation events, and we've had 44 of that 74 came from Simtending cases. And we essentially found that the 3 ways that we looked at the cases, so whether they were fulfilling their goals and objectives, whether the scenarios were realistic, and whether the feedback was high quality, we found that it was pretty much the same between Simtending and the traditional models, which basically means that we can get all of the benefits that we typically get from traditional simulation, as well as the new kind of helpful findings or helpful experiences from the specific Simtending model. So what do we want to do next and what can someone do next? So one of the great things about this is that not just that it's new, but also that it's scalable. That means that you can take it to a new program that an existing program that already has its kind of own simulation set up and modify it and add it to that simulation curriculum. And you can specifically use it to increase your engagement with your senior residents, so your PGY3s and your PGY4s. There's a commonly documented kind of phenomenon where the PGY3s and 4s, like your seniors, kind of tend to disengage because they're no longer getting new clinical stuff out of the simulation experience. So this gives them a brand new way to focus and a brand new way to challenge themselves. And for us in particular, the next steps for our project is to survey our recent graduates to find out what their impressions are and whether they felt that the Simtending curriculum helped them bridge the gap between being a senior resident and being attendings now. Thanks very much for listening, and of course, contact us if you have any questions.